Hello, and welcome back to the Therapeutics Chronicles. I'm your host, Momin Wali, and today we are diving into a medication that's been a game changer in hypertension, heart failure, and chronic kidney disease management, Candesartan. If you are a physician, pharmacist, or medical student, chances are you have prescribed or encountered this drug countless times. But even though it's a widely used medication, many clinicians underutilize its full potential or make common dosing errors that impact patient outcomes. Candesartan is often lumped together with other ARBs, angiotensin II receptor blockers, but it has some unique properties that make it stand out. Unlike losartan, which has a shorter half-life and requires twice daily dosing in some patients, Candesartan provides smooth 24-hour blood pressure control with a single daily dose. It's also well tolerated with fewer adverse effects than ACE inhibitors, making it a first-line option for patients who cannot tolerate ramipril or perindopril due to cough or angioedema. Before we get into the details, a quick reminder. Join our WhatsApp and Telegram groups where healthcare professionals are discussing real-world clinical cases, exam preparation, and patient management strategies. The links are in the description, and trust me, you don't want to miss out. And if you would like to connect professionally, feel free to reach out on LinkedIn, where we can continue the conversation beyond the podcast. Now, let's break it down. How does Candesartan work? When should we use it? And what are the key safety considerations that every clinician needs to know? Candesartan is a selective AT1 receptor blocker, meaning it prevents angiotensin II from binding to its receptor. Why does that matter? Angiotensin II is one of the most potent vasoconstrictors in the body, and by blocking its effects, we see a reduction in blood pressure, decreased aldosterone secretion, and improved sodium and water excretion. But unlike ACE inhibitors, ARBs like Candesartan do not affect bradykinin metabolism, meaning no annoying cough and lower risk of angioedema. Candesartan is clinically used in three major areas: hypertension, heart failure with reduced ejection fraction, and chronic kidney disease. It is considered a first-line agent in hypertension either as monotherapy or in combination with other antihypertensives like calcium channel blockers and diuretics. In heart failure, it is an alternative to ACE inhibitors. And in chronic kidney disease, it slows the progression of kidney disease by reducing proteinuria and glomerular hypertension. Dosing for hypertension starts at 8 mg once daily, titrated to 16 to 32 mg daily, depending on the patient's response. In heart failure, the starting dose is 4 mg daily, with gradual titration to a target dose of 32 mg daily if tolerated. The key mistake many clinicians make: not titrating the dose aggressively enough in heart failure. Many patients remain stuck on 8 mg daily, which does not provide the full mortality and morbidity benefits seen in clinical trials. A 65-year-old man with HFrEF, ejection fraction 35%, is on Candesartan 8 mg daily but still reports dyspnea on exertion and fatigue. His blood pressure is 110/70, heart rate 68, and he is stable with no signs of hyperkalemia or worsening renal function. The correct approach: increase Candesartan to 16 mg daily, monitoring renal function and potassium before titrating up to 32 mg daily if tolerated. Adverse effects are generally mild but require careful monitoring, especially in patients with chronic kidney disease, volume depletion, or those on multiple antihypertensives. Hyperkalemia is a known risk, particularly in patients on spironolactone or those with advanced kidney disease. Hypotension can occur in volume-depleted patients, especially those on loop diuretics like furosemide. Acute kidney injury, AKI, is another concern, particularly in patients with bilateral renal artery stenosis, severe heart failure, or those taking NSAIDs. A 72-year-old woman with chronic kidney disease, EGFR 38, and diabetes is on Candesartan 16 mg daily. At her follow-up visit, her potassium is 5.6 and she reports feeling fatigued. The best next step: consider reducing the dose or switching to a calcium channel blocker like amlodipine. If she remains on Candesartan, potassium levels must be monitored closely and dietary potassium intake may need to be adjusted. Candesartan has several important drug interactions that can affect its efficacy and safety. NSAIDs like like ibuprofen and naproxen can blunt its antihypertensive effect and increase the risk of acute kidney injury. Potassium-sparing diuretics like spironolactone and eplerenone increase the risk of hyperkalemia, while lithium levels can rise dangerously when combined with candesartan. For resistant hypertension, candesartan is often combined with amlodipine and a thiazide diuretic. In heart failure, the best approach is candesartan plus beta blocker plus spironolactone, a proven combination that reduces mortality and hospitalizations. A 55-year-old man with uncontrolled hypertension is on candesartan 16 mg and amlodipine 5 mg, yet his blood pressure remains at 150/90. What's missing? A thiazide diuretic such as indapamide or hydrochlorothiazide. A 68-year-old woman with HFrEF, ejection fraction 30%, is on bisoprolol 5 mg, candesartan 8 mg, and furosemide 40 mg daily. What's the next step? Increase candesartan to 16 mg before considering spironolactone. Patient education is critical. Patients should take candesartan at the same time daily. Avoid potassium supplements unless prescribed, and dry slowly from sitting to avoid dizziness. Regular renal function and potassium monitoring is essential, particularly in patients with CKD or those on diuretics. Now let's wrap things up with some rapid-fire Q&A. What's the maximum dose of candesartan in hypertension? 32 mg daily. Why is candesartan preferred over ACE inhibitors in some patients? No cough, better tolerability. What's the most common side effect? Mild dizziness or hyperkalemia in high-risk patients. Can candesartan be used in pregnancy? No, it is contraindicated due to teratogenic effects. That's a wrap up for today's episode. If you found this discussion valuable, be sure to subscribe and share this episode with your colleagues so we can continue spreading knowledge and improving patient care. Have a question about today's topic? Want to discuss clinical case or share your experience using candesartan? Join our WhatsApp and Telegram communities where healthcare professionals like you are engaging in real-time discussions about medications, therapy, and board exam preparation. The links are in the description. Do not miss out. If you would like to connect professionally, reach out to me on LinkedIn. I'm always happy to continue the discussion beyond the podcast and exchange insights with fellow healthcare professionals. And as always, stay curious, keep learning, and most importantly, catch mistakes before they catch you. Until next time, this is Momin Wali signing off. Take care.